You probably spend more energy worrying about how you look for the gynecologist than thinking about what your cervix actually looks like. You shave, you scrub, you spray, you push the appointment back because of spotting, and every single one of those moves quietly wipes out the information your doctor needs to keep you healthy. The irony stings. The harder you prepare, the less useful the visit ends up being. In this video, you're going to learn how to walk into a gynecologic exam in a way that makes the visit actually work for you. You'll see why shaving doesn't matter, why sex on the same day does, why deodorant in the intimate area is working against you, why waiting for abnormal bleeding to stop is risky, and why being extra clean before the appointment is, medically speaking, one of the worst things you can do. If you want this kind of health talk delivered straight and without the fluff, subscribe and hit like. Here on Dr. Waterling, the goal is 300,000 subscribers, and you genuinely do move that number. For practical checklists and short health posts, scan the QR code on screen. That takes you straight to my Telegram channel. Let's start with the question that makes a lot of women tense before an exam. Do I have to shave down there? You might even feel a flicker of guilt if you haven't. Maybe you reschedule because you aren't ready. From a medical standpoint, this whole worry is background noise. Your gynecologist is examining your vulva, vaginal walls, cervix, and taking samples from the cervical canal. Hair on the labia or mons pubis doesn't block the speculum, doesn't cover the cervix, and doesn't get in the way of a Pap test or HPV test. Hair is on the outside. Nearly everything your doctor cares about is on the inside. There's no scientific guideline anywhere that says patient must be shaved for accurate exam. None. Clinical guidelines focus on screening timing, smear quality, HPV testing, and follow-up protocols, not on hair grooming. Any sense of I have to be hairless is a social script, not a medical one. Your doctor doesn't hand out hygiene points for bikini waxing. They want data. What the tissue looks like, what the discharge looks like, what the tests say. Hair removal itself is a separate conversation. Shaving can leave microcuts, ingrown hairs, and local irritation. That alone can muddy the exam if you shave aggressively the morning of your visit. Redness, razor bumps, or small pustules can make the vulvar skin look inflamed. The doctor then has to spend time sorting irritation from the razor out of infection or skin disease. So if you like to shave, fine. Just leave enough time for the skin to calm down. Laser hair removal is a different story. The concern here isn't beauty, it's nerve biology. Laser works by sending controlled bursts of heat into each hair follicle until the follicle is destroyed. Heat is a strong pain signal. When the same area takes painful stimuli again and again, the nerve endings can respond by dialing down their sensitivity, a process called desensitization. It's a normal defense reaction of the nervous system. But in regions packed with sensory nerves, like the perineum and labia, this gradual dampening can mean less sensation over time. Desensitization itself isn't a disease, it's just something worth knowing about if sexual pleasure matters to you, and it does to most people. If you're planning laser removal in the bikini or labial region, it's worth asking the provider about proper numbing, cooling, and technique so you're not absorbing repeated strong pain signals during each session. Framing it as a medical comfort question, not a beauty salon issue, is completely reasonable. The second big mistake is having sex on the same day as your gynecologic visit and then not saying anything about it. On the surface, it seems harmless. You might even think, we use protection, so what's the big deal? The issue isn't infection risk in this moment. It's the cascade of short-term shifts in your reproductive tract right after intercourse. After sex, the vaginal mucosa, the lining, gets more engorged with blood. It looks swollen and red. If a doctor sees this without context, it can resemble irritation from an infection or a product reaction. At the same time, the amount and appearance of your discharge shift. You get a mix of cervical mucus, vaginal secretions, and semen. That hybrid discharge can be thicker, cloudier, or more abundant than your baseline, which complicates visual assessment. If a condom with lubricant or spermicide was used, those chemicals stay inside the vagina for a while. Many lubricants and spermicides sit on the alkaline side compared to your natural vaginal environment. And semen is alkaline too. Healthy vaginal pH normally lives in a clearly acidic range when lactobacilli are running the show. Studies of women with a lactobacillus-dominated microbiome show average vaginal pH values around 3.5. with lactic acid concentrations high enough to directly kill many pathogens. This acidity isn't random. It's one of your main defense systems against infection. When semen, lubricants, or spermicides raise the pH even briefly, it changes what a swab will show. A sample taken in that window can make your flora look more disturbed than it actually is. If you already have bacterial vaginosis or another imbalance, the shift can exaggerate the pattern. That matters because diagnosing conditions like bacterial vaginosis, yeast infections, and trichomoniasis leans on microscopic evaluation, pH measurement, and sometimes smell. Picture this. You go in with mild symptoms, but you had sex that morning. The pH is higher than usual, the discharge is mixed with semen, and the microscope shows a temporarily altered blend of bacteria. The doctor might still nail the diagnosis, but you've made the job harder than it needed to be. The simple fix: if you can, avoid vaginal intercourse on the day of your appointment. If it did happen, just say so plainly. That single piece of information lets your doctor read every finding more accurately. Third mistake: trying to fix the smell before the visit with sprays, perfumed wipes, or deodorant for the intimate area. This is the one almost every woman gets on an emotional level. You don't want to be the patient with odor. You want to come across as tidy and pleasant. The blunt truth is that by perfuming the smell away, you're erasing one of the most powerful diagnostic signals your doctor has. A healthy vagina is not smell-free. It carries a mild, slightly acidic scent that comes from lactobacilli producing lactic acid and hydrogen peroxide. When that ecosystem shifts, specific smells appear, and each pattern points toward a different process. Bacterial vaginosis is the classic example. It's an imbalance where anaerobic bacteria and other organisms outnumber lactobacilli. Guidelines describe a thin, gray, or white discharge with a distinctive fishy odor that gets stronger after sex because alkaline semen makes certain compounds more volatile. That smell is so characteristic that clinicians use it as part of the diagnostic criteria alongside pH and microscopy. Yeast infections, vulvovaginal candidiasis, work differently. They're caused by overgrowth of candida fungi. The discharge is usually thick, white, clumpy, and there's intense itching and burning. The smell tends to be sour or bread-like, not fishy. Trichomoniasis, a sexually transmitted infection caused by the parasite Trichomonas vaginalis, brings yet another pattern. Frothy, yellow-green discharge with a sharp, often foul odor, plus a rise in pH. Research shows that many women, and even some clinicians, confuse bacterial vaginosis and yeast infections based on symptoms alone, and misdiagnosis is common without proper testing. The treatments are completely different. Bacterial vaginosis usually needs antibiotics that target certain bacteria. Yeast infections need antifungals that target fungi. Slathering antifungal cream on bacterial vaginosis is like trying to fix a car engine problem by swapping out the tires. It does nothing useful and pushes real treatment further down the road. Now imagine you smother all odors with a strong floral spray before your exam. The doctor loses that pattern instantly. They still have pH, discharge appearance, and microscopy, but a whole piece of the puzzle is gone. It's like muting one audio channel on a recording and then trying to name the song. There's a pattern that keeps showing up in case reports and clinic notes. A woman, let's call her Linda, mid-30s, has been buying over-the-counter yeast infection treatments several times a year. She uses intimate deodorant almost daily because she's embarrassed by a persistent smell. When she finally gets a proper exam without any products in the way, her tests come back showing bacterial vaginosis, not yeast. She'd been treating the wrong condition for months. Her natural embarrassment and her attempts to smell better made it harder to see what was really going on. If you notice a new or strong odor that doesn't match your usual baseline, the healthiest reaction isn't, "I need stronger soap." It's, "My bacteria are telling me something." Odor isn't a moral failure. It's a message. Let the doctor receive it. Number 4 is the habit of waiting for abnormal bleeding to stop before you book an appointment. Spotting between periods, prolonged periods, bleeding after sex, or bleeding after menopause all get brushed aside with the same thought. Let me wait and see. Maybe it'll pass. Sometimes it does. Sometimes it doesn't. While you're waiting, 2 important things are happening. First, blood itself feeds bacteria. Studies on vaginal health and pelvic infections show that when the environment gets rich in blood, It's easier for bacteria to grow and to travel upward into the uterus and tubes. This is the same basic mechanism as with vaginal douching. Once the normal balance is disturbed, opportunistic organisms find their opening. An ascending infection from the lower tract into the uterus can cause endometritis, inflammation of the uterine lining. Chronic endometritis is often silent and has been tied to infertility, repeated implantation failure, and recurrent miscarriage in multiple studies. Adhesions, bands of scar tissue, can form inside the uterine cavity or pelvis after infections, surgery, or conditions like endometriosis. And those adhesions can interfere with conception and raise the risk of ectopic pregnancy or pregnancy loss. Second, the pattern of the bleeding is itself diagnostic information. Abnormal bleeding can signal many things: hormonal imbalance, fibroids, endometrial polyps, endometriosis, thyroid disease, pregnancy complications, or cancer. The timing, volume, color, and relationship to pain point the doctor toward or away from each of those. If you wait for weeks until the bleeding settles, you take that live snapshot away from your doctor. You arrive with a cleaned up picture and a fuzzy memory of what the pattern actually looked like. That slows everything down. For instance, bleeding after intercourse can be a warning sign of cervical pathology. Bleeding between periods in someone over 40 can be one of the first clues of endometrial hyperplasia or cancer. Guidelines from the World Health Organization emphasize that screening and prompt evaluation of suspicious symptoms are central to preventing cervical cancer deaths. The move that protects you isn't wait until this stops, it's let me book a visit now and describe exactly what's happening. A telling case from infertility practice. A woman in her early 30s has light bleeding almost every cycle, not quite lining up with her period. She brushes it off for years. When she finally seeks help for infertility, hysteroscopy, a camera placed inside the uterus, shows chronic endometritis with adhesions. Studies estimate that chronic endometritis may affect up to 1 in 5 infertile women and an even larger share of those with repeated implantation failure. Earlier evaluation of that odd bleeding could have caught the problem while it was still simpler to treat. The fifth mistake is the I'm going to be extra clean for the doctor routine. Long shower, strong soap, special intimate wash, maybe even a vaginal douche. It feels respectful. You think, they see so many patients all day, I should at least not smell like a normal human. The medical reality, every one of those steps distorts or wipes out diagnostic information. Douching is especially damaging. Large studies and reviews in journals and public health sources show that vaginal douching is linked to increased risk of bacterial vaginosis, pelvic inflammatory disease, ectopic pregnancy, and other complications. It works against you in 2 ways. It mechanically flushes out the lactobacilli that protect you. Then, by shifting pH and the environment, it favors overgrowth of harmful organisms. Think of it as ripping out the healthy grass in your yard and then wondering why weeds took over. Even without full douching, intensive washing of the vulva and scrubbing away every trace of discharge before the exam breaks the picture your doctor needs. During an exam, the clinician looks at color and texture of the vaginal mucosa, type and quantity of discharge, presence of redness, erosions, or plaques. They check for characteristic odors. They take swabs to analyze the microbiome, sometimes reported as degree of cleanliness. First degree means mostly lactobacilli and no inflammation. Second degree means mixed flora with some white blood cells. And third or fourth degree point to clear pathology. When you rinse, scrub, and soap everything minutes before the exam, the discharge carrying all that information gets reduced or gone. A swab taken afterward mainly reflects what's already regenerating, not what's been going on for days or weeks. Health information sites and clinical guidelines line up on this. The vagina is self-cleaning. It doesn't need active washing on the inside, and doing so raises risk rather than lowering it. For exam prep, less is more. Warm water on the external vulva and perineum is plenty. No soap, no antiseptics, no fragrance, no internal rinsing. A common scenario in medical records reads like this. A young woman, let's call her Emily, has been douching weekly because she believes it prevents infection and keeps her fresh. She also always showers thoroughly right before a visit. She comes in with mild pelvic pain and very light abnormal bleeding. Her initial swabs after a shower only show mild flora changes. Over time, her pain gets worse, and further workup turns up pelvic inflammatory disease and tubal adhesions. Epidemiologic research shows that regular douching is associated with significantly higher odds of pelvic inflammatory disease. And the suspected mechanism is exactly this disruption of protective flora and the easier path for ascending infection. So what does correct preparation actually look like? The medically boring version. On the day of your appointment, you go about your normal life. You don't shave just for the visit. You skip vaginal intercourse if you can. You skip intimate sprays, perfumed wipes, and deodorants for the genital area. You don't douche or wash inside the vagina. Shortly before heading out, you can rinse the external area with warm water only. That's it. If you're using vaginal medications, suppositories, creams, or tablets, your doctor may ask you to pause them for 2 or 3 days before the exam so they don't hide or mimic disease. That's something to clarify in advance with your provider. All of this talk about preparation only matters if you actually show up for exams. And here's where screening comes in. Cervical cancer is still a major global killer. The World Health Organization has estimated hundreds of thousands of new cervical cancer cases and hundreds of thousands of deaths worldwide in a single year, most of them in countries with limited access to screening. In the United States alone, the American Cancer Society expects around 13,490 new cases of invasive cervical cancer this year, and roughly 4,200 deaths. Those numbers fall sharply in places where regular Pap and HPV testing are standard. Cervical cancer grows out of precancerous changes in cells. These changes can sit there silently for years. You don't feel them. No pain, no obvious symptoms. Screening is built to catch these precancerous lesions so they can be treated long before they ever turn into cancer. The Pap smear examines cervical cells under a microscope. HPV testing looks for high-risk strains of human papillomavirus, which drive the vast majority of cervical cancers. WHO and other bodies now recommend that women be screened at least once or twice in midlife with a high-performance test like HPV testing, because modeling shows that screening 70% of women at around age 35 and again at 45 could drop cervical cancer rates dramatically over the coming decades. Different countries and organizations follow slightly different schedules, but the theme is the same. Regular screening saves lives. This is where age really matters. The risk landscape for abnormal bleeding, fibroids, endometrial changes, and cancer shifts as you move from your 20s into your 30s, 40s, and beyond menopause. Bleeding after sex at 20 might often be linked to a benign cervical ectropion or infection, while the same symptom after menopause is much more concerning for malignancy until proven otherwise. Endometrial cancer risk climbs especially after midlife. So here's what I want you to think about, and I want you to answer in the comments. How old are you right now? Your age changes which tests are top priority and how aggressive you and your doctor should be about certain symptoms. So knowing the age range of the people watching helps me build future videos that actually match your risk window instead of talking past it. Now, let's pull everything together into something simple you can hold on to. You don't need to change your body for your gynecologist. You don't need a perfect bikini line. Hair or no hair changes nothing about how well your cervix can be examined. If you like grooming for yourself, do it when it makes sense for you, not as homework for an exam. You don't need to be sexually inactive to see a gynecologist, but sex on the same day shifts pH, discharge, and the look of your tissues. If it happens, mention it clearly. If you can skip it that day, even better. That one choice can make your test results cleaner and the interpretation easier. You absolutely don't need perfume in your underwear area. Odor isn't a moral problem, it's a biological signal. Fishy, sour, or sharp smells each point toward different diagnoses, and masking them just slows you down. When you notice a persistent new smell, the healthy move isn't a stronger deodorant, it's an appointment. You really can't afford to wait and see with abnormal bleeding. Spotting between periods, bleeding after sex, bleeding after menopause, or periods that look very different from your usual pattern all deserve attention, especially as you get older. Infections, chronic inflammation like endometritis, and even early cancers often show up first through odd bleeding, not through dramatic pain. And you don't need to scour your vagina clean. It isn't a kitchen floor. Douching and deep washing wipe out your natural defenses and are tied to bacterial vaginosis, pelvic inflammatory disease, infertility, and ectopic pregnancy. Warm water on the outside is enough. Let the inside take care of itself. What you do need is a steady, low-drama relationship with your gynecologist. Regular checkups, honest answers when they ask about your symptoms, your sex life, your products, your cycles. Questions from you when something feels off. You bring your real, unedited body. They bring the tools and training. That's the deal. So your next step after watching this is simple. Pull up your calendar and think back. When was your last PAP or HPV test? And when was your last full gynecologic exam? If it's been a while, that's something to raise with your doctor's office. If you've been using douches, intimate deodorants, or regular over-the-counter yeast treatments without a clear diagnosis, that's also worth talking through so you can reset and get a real picture of what's happening. Everything we just covered is meant to give you clearer language and better questions for that visit. It's information, not a shortcut around personal medical care. Use it to show up more as yourself and to have a sharper conversation with someone who knows your full health story.